So this morning I was chairing the opening session on the Thursday, the second day of BTOG, and we had 4 fantastic talks, kind of spanning quite a diverse range of subjects. The first one was about the new staging system for thoracic cancers. This is the TNM 9 classification. We've been living with TNM and 8 for the past 2 years, and 9 is obviously the new iteration. It's not only for non-small cell lung cancer, it's also for thymic tumours, and it's for mesothelioma. And it's a complex area. The idea behind having new staging is we break down tumours into smaller groups so we can better understand prognosis. And the new changes reflect the fact that sometimes subtle differences in disease distribution have impacts on survival. So it's important that we describe that in our nomenclature. So for example, the new iteration for non-small cell in this TNM 9 includes patients with single-station N2 disease and multi-station N2 disease. These are now separated, and that gives us important prognostic indication. There's also, for example, a differentiation between single site of metastases and multiple sites of metastases. So that was from Prof. Schill. He did a beautiful presentation on that. And it was followed by a presentation by Fiona MacDonald, who is a clinical oncologist at Royal Marsden Hospital, about staging, systematic staging EBUSs in patients with locally advanced disease amenable to chemoradiotherapy approaches. And this is on the back of the Seismic study, which was published recently in one of the major journals. What this showed is quite a discordance between what is found radiologically and what is found at EBUS pathologically in terms of staging the mediastinum. And it raises the important issue of ensuring that we know absolutely what is going on within the mediastinum before we commit to treatment. And with this study, in the Seismic study, it was found that treatment plans frequently, in fact usually, changed when patients were upstaged or downstaged as a result of that systematic staging of the mediastinum. The third talk was from Matthias Guggenberger, and this was about radiotherapy for bone metastases, and in particular stereotactic radiotherapy for bone metastases. And he focused on 2 areas. One was the idea of using that in oligometastatic disease, and there's increasingly evidence that that is beneficial in terms of longer-term control of the disease. And he also focused on stereotactic radiotherapy as a palliative treatment. I think that's particularly interesting because that perhaps includes a larger number of patients because bone metastases are so common. The principle behind this is that conventional radiotherapy for bone metastases is done very frequently, but it doesn't always work. It doesn't always work completely. It doesn't always work for very long. And the evidence behind stereotactic radiotherapy is that you are able to get better control and longer control with that radiation. Now, it has its own challenges. It's a more difficult procedure to do in terms of resource requirement, and we need to make sure that we do have the resources in place to implement that. But I think that is important information, important data as we move forward with our patient treatment. And then the final talk was from Mary O'Brien, also from the Royal Marsden Hospital, and she's describing a really important study going on in the UK, NIHR-backed, called the REFINE study. And the REFINE study is absolutely essential. What this is looking at is, can we change and de-escalate the intensity and frequency with which we give immunotherapy? And that's important because of the cost of immunotherapy and growing data that immunotherapy is actually occupying the PD-1 binding site longer than the 3 to 6 weeks interval that we're giving it. And so this very pragmatic study is trying to investigate de-escalating that. It's an ongoing study in multiple sites in the UK. It has been quite slow to recruit, so we're very keen that anyone who is able to open the study does so, because I think it's a great benefit to our patients.